Sometimes you really want to get your head around a complex topic, but just figuring out where to start is, well, it's tough.
Exactly, and that's what we try to do here. Cut through it all.
So today we're tackling something specific, Fibrocartilaginous Embolic Myelopathy, FCEM. Sounds serious.
It can be, yeah. We've looked at some detailed veterinary sources to really break down what FCEM actually is, which animals tend to get it, and, what the implications are.
Okay. Mission accepted. Let's get the core info out there. So basics first. What is FCEM?
Okay, so fundamentally, FCEM is a type of stroke affecting the spinal cord.
A stroke in the spine.
Yeah. Essentially, a blockage forms in the blood vessels feeding the spinal cord. This cuts off blood supply, and that leads to tissue death. The technical term is acute ischemic necrosis.
And the blockage itself, what's that made of?
It's called a fibrocartilaginous embolus, basically a tiny piece of fibrocartilage.
Fibrocartilage, like
Yeah.
from the discs between the vertebrae?
That's the leading theory, yes. Material from the intervertebral disc, or maybe even bone marrow from inside the vertebral bone itself, somehow gets into the spinal arteries or veins.
But how it gets in there?
But that's the million-dollar question. The exact mechanism isn't fully understood. It's still a bit of a puzzle, honestly.
Fascinating. Okay, so that's the what. Who does this tend to happen to? Is it common?
We see it most often in dogs, specifically non-chondrodystrophic breeds.
Non-chondro. Okay, so not the breeds with the short legs and long backs, like dachshunds.
Exactly. Think more like labs, German shepherds, retrievers,
Yeah.
dogs with more standard proportions.
And among those are certain types more at risk.
Yes, definitely. Large and giant breeds actually have the highest prevalence. Great Danes, Irish Wolfhounds, that sort of dog.
Makes sense. Maybe bigger structures, more potential. But you mentioned others too.
Right. What's interesting is it's also overrepresented in a couple of smaller breeds. Miniature Schnauzers and Shelties, Shetland sheepdogs.
Huh. Why them? Is there a different reason?
There's a theory it might be linked to something called hyperlipoproteinemia. Basically, high levels of fat or lipids in the blood.
High cholesterol, like in people.
Sort of, yeah. High fat levels can make the blood thicker, more viscous.
Like honey instead of water.
That's a good analogy. And that really thick blood, it might struggle to get through the tiny spinal vessels, potentially causing an infarction, tissue damage from lack of blood flow, even without a piece of cartilage blocking things.
So two potential paths leading to a similar spinal cord injury in those breeds. Interesting. What about cats?
It's known to happen in cats, but it's considered quite rare. And just to reiterate, it's not really reported in those chondrodystrophic dog breeds at all.
Okay. And age. Does it affect older dogs more?
Typically, affected dogs are young to middle-aged adults. The usual range is, say, 3 to 5 years old, prime of their life, often.
Wow.
Yeah, but we have seen it in puppies as young as 16 weeks and in dogs up to 10 years old, so there's quite a range, and maybe a slight tendency for males to be affected more often.
Okay, so a young, large breed male dog might be the most typical, but it varies. How does it start? What signs should someone look for?
The onset is almost always very sudden, abrupt. Often it happens during or right after some kind of activity, maybe just running around the yard, playing fetch. Nothing extreme necessarily.
Just normal dog stuff.
Pretty much. And a really common feature owners report is the dog yelping or crying out, apparently in pain, right when it happens.
Okay, so initial pain, does that last?
That's the key, usually not. The pain tends to be very short-lived. We're talking minutes, maybe an hour or two at most, and then it subsides.
That could be confusing. The pain stops, but the problem isn't gone.
Exactly. After that brief pain, the neurological signs appear very quickly. This could be weakness paresis or complete paralysis. It develops rapidly over seconds, minutes, maybe a few hours.
And then does it keep getting worse?
Generally, no. And this is critical for diagnosis. The condition usually stabilizes within about 12 to 24 hours. If the signs continue to worsen after that 24-hour mark, you really need to suspect something else is going on.
Right, that's a huge diagnostic clue.
Yeah.
Is the weakness usually symmetrical? Both sides the same?
More often, it's asymmetrical or lateralized. One side of the body is clearly worse off than the other.
So one leg might be weak, the other, okay.
Or one side significantly weaker, yeah. The less affected side might just have mild deficits or even seem totally normal. Symmetrical signs are less common with FCEM. And like we said, by the time the vet sees them, usually hours later, they're typically not painful anymore.
Okay. And can this happen anywhere along the spine? Neck, back, lower back?
Yes, any segment can be affected. It just depends on which blood vessel gets blocked by the embolus.
So the symptoms would vary a lot depending on the location.
Precisely. You could see anything from just mild wobbliness, ataxia, to complete inability to move the limbs. It can affect upper motor neurons or lower motor neurons, which changes the reflexes and muscle tone you see.
The sources mentioned odd combinations of signs being possible. What does that mean?
Yeah, that's because the blood supply to the cord is quite specific. An embolus might block only a small branch feeding, say, just the top half or just one side of the cord at a certain level.
Ah, so you could get weird mixes of symptoms.
Exactly. You might see weakness in a leg, but the sensation is okay, or maybe loss of sensation, but muscle tone is normal. These sort of unusual patterns where not everything fits a typical spinal cord lesion can actually be another clue pointing towards FCEM.
Okay, so summing up the picture. Sudden onset, often after activity, brief initial pain that goes away, non-progressive weakness or paralysis after 12-24 hours, often worse on one side, and usually not painful on exam. That's quite specific.
It is. Those are the classic hallmarks we look for.
So what else could it be? What are the main things a vet needs to rule out? The differential diagnoses.
Good question. That cluster of signs, acute, non-progressive, asymmetric, none are painful, really flags FCEM. But you have to compare it with conditions that do cause ongoing pain and are often more symmetrical.
Like a slip disc.
Exactly. Intervertebral disc disease is a big one. Also, infections of the spine like discus spondylitis, spinal tumors, or even fractures or dislocations of the vertebrae. These usually cause significant pain.
And how do you tell those apart?
Imaging is key there. Regular x-rays might show a fracture or signs of infection, but often you need more advanced imaging, MRI, CT scans, or maybe myelography where dye is injected around the cord. These help visualize the spine and discs much better.
Any other mimics? Things happening inside the cord itself.
Well, you could have bleeding within the spinal cord parenchymal hemorrhage.
What would cause that?
Could be trauma or sometimes issues like poisoning with certain rat baits that affect clotting or other bleeding disorders. Blood tests checking clotting factors are important there.
Okay.
And then there's myelitis, inflammation of the spinal cord, but myelitis usually progresses. It gets worse over time, not stabilizing, like FCEM. And looking at the cerebrospinal fluid, the CSF, can often help identify inflammation.
All right, the CSF tap. So let's talk diagnosis then. If you suspect FCEM based on the history and exam, what tests confirm it?
Well, routine blood tests and urine tests are usually normal. They don't help much directly with diagnosing FCEM itself, but they're good for ruling out other systemic problems.
And plain x-rays.
Also typically normal. They can help rule out fractures or obvious bone issues, but they don't show the spinal cord itself or the embolus.
So you need the fancy imaging, MRI, CT.
Advanced imaging is really where it's at for FCEM. MRI, magnetic resonance imaging, is generally considered the best technique, the gold standard.
What does MRI show in an FCEM case?
It can show specific changes. On certain MRI sequences, particularly T2-weighted images, you might see subtle signs like maybe decreased signal in the suspected source disc, and then importantly, increased signal indicating swelling or edema within the spinal cord itself, right at the level of the injury.
So it directly shows the damage in the cord.
Exactly. Myelography or CT myelography might show some spinal cord swelling early on, or maybe shrinkage, atrophy later, but MRI gives a much better view of the cord tissue.
What about the CSF fluid analysis you mentioned? Is that helpful?
It can be variable. Sometimes in the very acute phase, you might see a slight increase in red blood cells or certain white blood cells, maybe a mild protein increase a few days later.
But not always.
Correct. It's also quite common for the CSF to be completely normal in FCEM cases. So it can help rule out inflammation, but a normal CSF doesn't rule out FCEM.
Okay, so MRI is the most definitive diagnostic tool.
Mm-hmm.
Now, stepping back, if you could look inside, what does the damage actually look like pathologically?
Grossly, meaning what you see just by looking. There'd be a focal area, a specific spot of swelling, and probably some hemorrhage, some bleeding in the cord.
And under the microscope?
Microscopically, you'd actually see the culprit, the fibrocartilage emboli, physically blocking the small arteries and veins within the spinal cord tissue, and maybe in the surrounding membranes, the meninges.
You can actually see the blockages.
Yes. And around that, you see the consequences. Tissue death, that ischemic necrosis we talked about, often with bleeding, and a softening of the tissue, which is called myelitis, affecting both the gray and white matter of the cord.
Wow. Okay, so damage confirmed. How do we manage these cases? What's the treatment plan?
First off, They usually need to be hospitalized initially, both for the diagnostic workup and for supportive care. Nursing care is absolutely crucial, especially if the dog can't move well.
Like preventing bed sores.
Exactly. Good padded bedding, turning them frequently, keeping them clean and dry. Bladder management is also critical. If they can't urinate on their own, the bladder needs to be expressed manually or a catheter placed to prevent overstretching and potential infections.
And getting them mobile.
As soon as possible, yes. Assisting them to stand and walk, even with slings or support. Rehabilitation therapy plays a big role here.
Like physiotherapy for dogs.
Sort of, yeah. Hydrotherapy can be fantastic swimming or using an underwater treadmill. The buoyancy of the water helps support their weight and makes movement easier.
That sounds helpful. What about managing them at home?
Good support is key. The sources mention a specific type of harness, the Roughwear Webmaster. Seems popular because it provides good body support and has a handle, making it easier for owners to help lift and guide the dog.
You mentioned activity earlier. Restrict or encourage?
Initially, some restriction might be needed while ruling out other things like unstable fractures. But once FCEM is confirmed, controlled activity should actually be encouraged to help with recovery.
Okay. Any special diet?
Usually just their normal diet is fine, unless they have that hyperlipidemia, the high blood fat issue. In that case, a low-fat diet is recommended.
And owner education sounds vital.
Absolutely. Owners need to understand that recovery can be slow, it takes time and patience, and requires a significant commitment to home care. It's not a quick fix.
Is surgery ever used?
No, surgery has no role in treating FCEM itself. The damage is from the blockage, not something surgery can typically fix.
Okay. What about medications? Any drugs that help?
This is a bit of a debated area. There's one drug, methylprednisolone sodium succinate. It's a potent steroid that might offer some benefit, but only if given very early.
How early?
Within the first 8 hours of the signs starting. This is based on studies of spinal cord trauma, not specifically FCEM, but the idea is to reduce secondary inflammation and swelling.
And it's a specific protocol.
Yes, a very high dose given intravenously, followed by more doses over the next 24 to 48 hours. But honestly, its effectiveness in FCEM is controversial, not definitively proven.
Are there downsides to using it? Risks?
Oh, definitely. A major one is the risk of gastrointestinal ulcers, especially if used alongside NSAID's non-steroidal anti-inflammatories. You absolutely should not combine them.
So no NSAs with this steroid?
Correct. And using the steroid for longer than that initial 24, 48-hour window doesn't seem to add benefit and just increases the risk of side effects. Some even suggest feeding a high-fiber, low-fat diet during and after steroid therapy to try and minimize ulcer risk.
So medication seems like a very limited, time-sensitive, and potentially risky option.
That's a fair summary, yes. Supportive care and rehabilitation are really the mainstays of management.
What's the long-term picture then? Follow-up, prognosis?
You need close monitoring, especially in the first day, then regular neurochecks over the next few weeks, say at 2, 3, and 4 weeks. Watch for ongoing issues like urinary incontinence, which can lead to UTIs.
Can it happen again? Recurrence.
It's considered rare, but yes, recurrence is possible. Unfortunately, there's no known prevention in most cases. If hyperlipidemia was diagnosed, then managing that with diet and maybe omega-3s is recommended.
What are the potential lasting problems?
Besides recurrence, long-term complications could include persistent fecal or urinary incontinence, chronic UTIs, or skin problems like pressure sores if mobility remains very poor.
And the big question, will they recover? What influences the prognosis?
It really hinges heavily on their neurological status right after the event stabilizes. The single most important factor is whether they still have conscious pain perception, sometimes called deep pain, in the affected limbs.
If they can still feel pain, that's good.
Yes, if pain perception is present, especially with upper motor neuron signs, the prognosis for significant improvement, maybe even walking again, is generally considered good to fair.
And if they can't feel pain?
If deep pain sensation is lost in the affected limbs, the prognosis is unfortunately poor.
What about reflexes?
If there's a complete loss of reflexes, arflexia in the limbs, or the anal sphincter, the chance of recovery is considered almost nil. If movements and reflexes are just reduced, functional recovery is often possible, but they might always have some lingering deficits.
Are there signs that indicate a very bad outcome?
Yes. If the neurological signs actually worsen after the initial 24 hours and spread, especially involving lower motor neurons and expanding sensory loss, that can indicate a devastating condition called myelomalacia, basically, progressive softening and death of the spinal cord. That carries a grave prognosis, and humane euthanasia is often discussed.
That's sobering. What's the typical recovery timeline if things are going well?
Improvement can be slow initially. You might not see much change in the first week or two. Most of the significant gains usually happen between week 3 and week 6.
And the nerve repair itself?
The process of remyelination, repairing the nerve coverings, is typically complete within about 6 to 12 weeks in dogs that recover. If you're not seeing any real improvement by week 3 or 4, sadly, it becomes less likely that significant recovery will occur.
Okay, let's try to bring this all together. FCEM is this sudden, often exercise-linked spinal cord event
Right, caused by a blockage.
that crucially doesn't get worse after the first 24 hours or so. It's often one-sided, not very painful after the initial onset.
Key features, yes. And diagnosis really leans on ruling out other painful progressive conditions, often with the help of MRI.
And the outlook, the prognosis, is incredibly varied.
Right.
It really depends on how severe that initial damage is, especially whether the dog retains that deep pain sensation.
Absolutely. That initial neurological exam after stabilization is critical for predicting the potential outcome.
It's quite something, this sudden event, often without a clear trigger, having such a potentially dramatic impact. It makes you wonder, doesn't it? Given that the exact how that cartilage gets into the bloodstream is still a bit hazy, what kind of research might help us understand this better? Could we potentially identify dogs at higher risk, or maybe find ways to prevent it in those breeds we know are susceptible?
That's the hope, isn't it? Understanding the underlying cascade of events better could, theoretically, open doors to prevention or maybe even more targeted early interventions.
This certainly highlights the body's complexities and how things can change so rapidly. Lots for us and for you listening to think about.